So, um, I work full time in the NHS, and I split my time. 2/3 of my time is within the hospitals of both the Royal Hampshire County Hospital in Winchester and the North Hampshire Hospital in Basingstoke. And I spend my time in the emergency departments as one of the emergency medicine consultants. And the other third of my time I spend with the Hampshire and Isle of Wight Air Ambulance based at Thruxton. So I've been a consultant in what's now Hampshire Hospitals since 2008, and also I've been flying with the Hampshire and Isle of Wight Air Ambulance since 2008 as well. So my roles in the two are hugely different. The emergency department is very, very busy and very pressured, and we're running a large team of doctors, nurses and allied professionals at any one time. Whereas the air ambulance, we're fortunate enough, often not always, to be looking after one patient at a time. Occasionally we have multiple patients, but usually it's one-to-one critical care and doing quite complex medicine, as I will go on to discuss. So I've got a video here that I'm going to share with you. I think it's useful to remember that because a lot of people don't realise this, that the air ambulance, as with virtually all the air ambulances in the UK, are completely charitably funded. There's no NHS or government funding to support us at all. Everything we do is through the donations of the population of Hampshire and the Isle of Wight. This covers everything from the fuel in the cars and the helicopter to the helicopter itself, to the provision of all the staff and support staff. So this is one of the promotional videos from the website, but actually it gives a good flavour and helps to set the tone of the talk. So if I can make this work. One second. So that is quite powerful and is, I think, helpful to remember that everything we do is completely funded by the goodwill of the people of Hampshire. I do have another video in a minute, which is similar but different. So, Helimed 56. This is our air ambulance. Every air ambulance in the country has a code word, username. Helimed 56 is ours. For example, the Thames Valley aircraft is Helimed 24. We run 2 shifts a day. We start at 7 in the morning and go till 7 in the evening with the day shift, and the late shift starts at 4 and runs through till 2 a.m. Sometimes, for operational reasons, the late shift is on a car, and we'll talk about a little bit more about both the aircraft and the car shortly. So this is our aircraft, sat outside our hangar at the Thruxton aerodrome up just beyond Andover. This hangar is purpose-built and was built about 5 years ago, specifically for the aircraft and to house the whole team. So we've got not only storage facilities, we've got the cars are based there as well, all the sort of sundries and drug supplies and things that make the whole system go round. But we've also got offices and training rooms there as well. The aircraft has to come in and out every day. We don't leave her out overnight, and we have a complex heli lift machine that helps to lift her up and carry her inside. And she fits perfectly inside the hangar. We have our own team, maintenance team, that look after her and do all the appropriate things to keep her flying. And she's really quite handsome. Over the years, since the charity started in 2007, we've had a number of aircraft. This one's now been with us, I think, for the last 3 years, and is state-of-the-art. She's a Eurocopter 135, for those of you who are interested in such things. And she's also capable for night flying, and we have night vision goggles that the pilots use, and the big searchlight on the front helps to make all of that work. So I'm going to show you the second video now.
Libby is a cheeky, fun, loving, caring, typical 8-year-old little boy. The 22nd of March 2018 was a normal, typical day. Richard walked up to school to collect the boys, and they were on their scooters coming down the pavement, which they did every single day. It was completely normal. And as they were coming down the hill, a car crossed the pavement and took Willoughby out. Willoughby fell off his scooter, went underneath the car, and came sort of up the other side, and the car had no idea it had hit Willoughby and actually thought he'd just gone over a speed bump.
I saw the car wasn't stopping, carried on, so I ran down the hill screaming. Willoughby was quite quiet. As I got to him, he just said, "Sorry, Daddy, it was my fault, he didn't stop." So his ear was basically touching his shoulder by the looks of it, and Anna, the off-duty nurse, she was having a coffee across the road. She came running over, looked at him, and basically just grabbed hold of his ear and put it back where it was, sitting on his head, and just held tight.
There was a lot of people, wasn't there, suddenly around, and they were comforting George at the time, who kept saying to you, "Is he going to die, Daddy? Is he going to die?" And you were like, "Oh, I don't know if he's going to die." I got the phone call at work, and I immediately went to QA Hospital in Portsmouth, where I thought that he was going to be taken. And I ran into A&E there, and I said, "Is Willoughby Copeland here?" And they said, "We've never heard of him." And that was at the time when you phoned and said, "No, his injuries are so serious that they've called the air ambulance." And he isn't going to go to QA, you need to come here to the scene. I arrived, and then the critical care team doctor came in the ambulance with us, and we flew to Southampton. All of the way to the hospital, the doctor was just amazing and really calm, and was just talking to me the whole time about each of Willoughby's injuries and what to expect when we arrived at Southampton, and what it was going to be like in A&E, and who was going to talk to him, and how big the team was going to be, and everything that he kind of explained ended up happening. So that was really good for me, when you're there with your son who's in and out of consciousness because he's so drugged up at that time, for someone just to be really calm and really clear about what was happening to Willoughby and what was going to happen next, was, I think, really good for all of us.
Yeah.
Willoughby is doing really well now. He was quite a long road to recovery. He couldn't eat properly for quite a few months and had to have a full operation in the summer. But he's doing really well. He's back playing rugby, which he loves doing. So life has kind of gone a bit back to normal again, which is lovely. Thank you for saving my life.
So, we are hugely lucky to be so well supported by so many of our patients. Many of them come back up to the airbase to visit and to meet the team, and meet the team that worked with them when they were poorly. And in fact, a number of those individuals now not only supporting us by doing promotional work, like those videos, but some of them actually now work with the charity and have made the air ambulance their career, which is rather exciting. So, a normal day for us starts at 7 in the morning. We have to get the car and the helicopter ready so that we can go out as quickly as possible. There's every possibility that there will have been a call waiting, and that ambulance control will have been waiting for us to log on. And so we need to be to get everything as ready as quickly as possible. All the electronics within the medical kit has to be checked to make sure that the batteries are all serviceable, and that all the bags have to be checked, and as do the drugs, as we carry quite a significant array of medicines to do what we might need to do. Everything is checklist based. Thankfully, all now with excellent IT solutions to help it, but it takes us about 15 minutes to go through everything, so that we're ready to go. We'll always have a weather briefing. As you can imagine, flying and often quite complicated flying, we're hugely dependent upon the weather. During the daytime, we are allowed to we need a cloud base of 500 feet. If there isn't that, then we can't fly. So when there's fog or mist, it means that we're offline and we have to go on the car. But we also have to be pretty careful of things like thunderstorms. High winds aren't too bad. When we're flying, actually the high winds are much more complicated when we're starting the aircraft up, and that's when the rotors are at most at risk. Icing can be a problem for any aircraft, and especially at this time of year. So we try not to fly in cloud as much as possible, because that, especially at the moment, the cloud is often freezing, and it will deposit ice onto the body of the aircraft and onto the rotor blades. The technical briefing that the pilots give us is actually fascinating, and I've learned more about meteorology than I had ever expected to do. So the briefing usually takes about 10 to 15 minutes, and not only do we go through the weather, but we go through other aviation problems and hazards that we might face that day. and usually run through some emergencies as well, just so that everybody's on their toes, just in case something untoward should happen. Then we're ready to go, and we then just wait. There's plenty to do while we're waiting. We'll often train and run through scenarios, but we'll also check the kit. The kit that we carry, we've got about 5 main bags that we carry with us, and there's 4 sets of those, and they all need to be checked in rotation to ensure that the various bits of equipment haven't gone out of date, and that everything is as it should be. Training is a huge part of what we do. We have to be ready to work as a team with the variety of things that we might face. And of course, COVID has been quite complicated for us. Here's 2 of my colleagues in our COVID PPE of about 9 months ago. The kit has now changed slightly, but as you can see, it's quite all-encompassing. Beneath that, we wear our normal PPE, personal protective equipment, for having to be in the helicopter and being in challenging scenes that we might attend. Often the scenes we go to can be quite dangerous, industrial sites, motor vehicle accidents, and so the PPE we wear under as our normal PPE is fire resistant and quite rugged. Then to put this extra layer on top makes us pretty well wrapped up on a hot summer's day, and it was pretty difficult in the height of COVID with the full layers of PPE that we were wearing at that point. But then we could get a call at any point. The calls come to us through ambulance control. So the 999 call, all of our 999 calls across Hampshire are monitored by, we have one of the paramedic team and a call taker are sat in the ambulance control room and surveying the calls all the time, just waiting for those buzzwords or a call that looks particularly complex that might require our services. If a call should be identified, then we get a quick radio call. We all carry our radios with us at any point when we're on base, and then they can dispatch us. A number of things are automatic dispatches. For example, stabbings or ejection from a vehicle. Those, if the call handler detects that something like that has happened, we just get automatically dispatched. So within somebody having made the 999 call, within about a minute, we could also be en route to them, which is really quite impressive. So here we are, we've been dispatched. This is me now sat in my seat in the back of the aircraft, and we're doing our pre-flight checks at this point. Usually once we have started up the aircraft, it takes us about 90 seconds to go through all the pre-flight checks and get to a point where we're able to take off. And we can get to pretty much anywhere in Hampshire and the Isle of Wight within about 15 minutes. The flight is not without its complexities, and as you can see by this image, Hampshire is beautiful in summer, but there are things that we still need to watch out for, and it's all of our responsibilities in the aircraft to be keeping our eyes peeled for anything that could potentially be a danger or a risk. There are an awful lot of gliders around Hampshire and microlights, which are often quite difficult to see. This particular hazard is slightly bigger and more obvious, but not all of them are. So we'll land where we can. As you can see, in this instance, the pilot has landed us on a bridge, and then we'll make our way to the scene. The pilots are really quite amazing, and they'll land us as close to the scene as they possibly can, but sometimes we do have a reasonable trek. We'll have been given very rudimentary information about what we're going to, and so we will need to as we approach the scene, start to gather more information from either the emergency services or just looking around us. As you can see here, my colleague is walking over some debris, and this particular incident was only another 40 meters down the road, and this was some debris from that. So part of what we do is having to work out what has happened. We can often be the first emergency services on scene, so we haven't got somebody else to carefully explain what has happened to us. So we often need to work it out for ourselves. We need to look at if it's a road traffic accident, we need to look at the road, we need to look at the markings, the debris trail, to try and understand what has happened. The better we know what has happened, the better we can work out what the injuries are likely to be, and then how we can treat them. People have very different injury patterns depending on what's happened to them. As you can imagine, somebody who has had a frontal impact into, say, a wall or a tree has a very different set of injury patterns from somebody who might have been ejected from a vehicle or perhaps fallen from a height. So if we can predict these patterns, it gives us a much better chance of stabilizing things and getting and making the treatment as quick and as slick as we possibly can. There's lots of things that we might need to do. There are some operations that we do, fortunately not commonly, but I'll talk about those a little bit later. We have the ability to put people on what we would call life support, where we would take over their breathing for them and put them onto a ventilator. We carry blood and other blood products so that people who are having significant hemorrhages from their incidents, we can stabilize them and bridge them to the point where we can get them to the hospital. And we do carry a variety of different medicines that allow us to work in a variety of different conditions, both traumatic and medical. So we then have to have a think about where we might take our patient. Trauma centres have become, is something that has happened since 2012, but prior to 2012, trauma care in the UK wasn't what we call networked. In 2012, every region was provided with a trauma centre, and then every other hospital in that region either became what's called a trauma unit or a local hospital. We know from other medical conditions that if you develop specialised centres where the team has the dedicated experience and equipment and treats those conditions on a regular basis, that actually patients do far, far better. With trauma, often we need a whole huge range of different specialities to treat our patients, and so it was most sensible that the larger hospitals and usually teaching hospitals became the trauma centres. So in our region, we have Southampton, and this is the main trauma centre that we go to. But we do also go to Oxford and to Bristol, depending on where the patient where we've picked the patient up. And very occasionally the team go up to London, most notably St George's. And I'll talk a little bit more about trauma centres in a little bit. Then we've got more decisions. Do we go by land or by air? I think many people think that we will fly our patients most of the time, whereas actually it's we probably only fly perhaps 10% of the time. The helicopter is most useful for getting us to the patient. To put the patient back in the aircraft often will take about 10 minutes, and we need quite a lot of bodies. Often it's across a field, and we will and And that 10 minutes, if we are already in the back of an ambulance, is time that we would have been often, with considering the geography of Hampshire, is often we would have been a significant way to the hospital as it is. At the other end, depending on which hospital we've gone to, we again sometimes actually need an ambulance to take us from the helipad to the emergency department. Southampton is good because we don't need to. It's about a 3 or 4 minutes trolley push from the helipad on top of the car park. Every incident we go to varies, and it depends upon the circumstances, the time of day, the road conditions and the flying conditions as to whether we choose to go by road or by air. And the pros and cons need to be weighed. It is possible to do complex procedures in the back of the aircraft, but there isn't a huge amount of space. And so if we are going to continue to be working to support the patient and do procedures, often we'll go in the back of the ambulance. So then we need to let the hospital know that we're coming. We're going to be bringing them something quite complicated, which is going to cause them a couple of problems. And if we can give them as much notice and warning as possible, then they will be able to get whatever the patient's going to need ready. So we give them what's called an APMIST. So we'll give them the patient's age, give them the time of the incident, followed by a quick summary of the injuries, the signs and symptoms that the patient may have, and the treatments that we've given. If I give you an example, so we have a 25-year-old man at 3:30 this afternoon, fell from a tree about 20 meters. He appears to have a fracture to his right femur, and back injuries. We've given him analgesia and splintered his leg, and we will be with you in about 20 minutes. So going back to our original patient that we picked up, in this instance we have flown him, and this patient, and this is quite a nice shot of us flying across the Solent. And this is our senior pilot, Dave. This isn't the hospital we would have flown to on that incident, because this is actually the helipad at Oxford. So flying across the Solent, we would have ended up at Southampton. And I give you some further examples of the other places we visit later on in the talk. So, and in fact, this is the helipad at University Hospital Southampton, which has just been refurbished and is good. So, network care. So prior to the trauma centres being created, if you had a significant traumatic incident, you would just be taken to your local hospital, and that local hospital would have invariably struggled with your care, but have done everything that it could possibly do. But as would be expected, patient outcomes were not quite what they needed to be. And as network care has become much more common for a whole range of specialities, stroke, vascular, and for a whole range of different surgical needs and transplants, it had been becoming increasingly apparent that if we did this for trauma as well, that it would help considerably. This is the University Hospital in Southampton. This picture is now a couple of years old, as they've built a new wing at the front, but you can see the helipad at the front on the main car park. So we mentioned some of the other treatments that we might need to do. So there is the possibility sometimes that we need to perform roadside operations. Thankfully, these are quite rare. And they will go. I'll come back to those in a little bit. the life support. So we sometimes, in fact, probably the most common procedure that we do, complex procedure that we do, is give somebody a general anaesthetic. And we do this for a variety of reasons. Often it's to protect the airway because the patient is too poorly to protect it themselves. They're at risk of vomiting and aspirating, or they're at risk of just not breathing well enough and suffering what we would call a secondary injury. The primary injury is when they had their initial trauma, when they had their road traffic accident, or when they fell from a height. And much of this is about neuroprotection. The brain is incredibly delicate, and once it has had an initial significant injury, the risk of it having a further injury, a secondary injury, is very high. If we can stabilize the patient, maintain their blood pressure so that there is an adequate blood supply and oxygen supply to the brain, there's very, very good evidence now to show that we can decrease the risk of further problems and further potential disability or death. So by giving somebody an anaesthetic and maintaining their airway, we can do that. It's not without its risks. Giving somebody an anaesthetic anywhere is not without its risks, and so the training and processes that we go through are really quite rigorous to ensure that it goes as smoothly as possible. We measure carbon dioxide levels in the expired air. This gives us a pretty good idea of what the carbon dioxide levels are in the bloodstream. There's typically quite a close correlation between the two. We know that by managing CO2 levels, we can help to manage the intracranial pressure. The skull is a fixed box, and often after a blow to the head, there's bleeding and swelling within the skull. That means that the pressure is going to start rising, which is often a significant problem that can lead to a secondary brain injury. By managing the CO2, we can help control that. Often when people are significantly obtunded and in a coma, they don't breathe properly, and their CO2 levels rise. When your CO2 levels rise, you often your blood vessels dilate, and that dilated blood vessels within the head takes up much more space. And by controlling the CO2 and bringing that down, by correcting that, it means that there's more space in your head, so that any bruising or swelling that has happened is controlled and contained as far as possible while we get you to a neurosurgeon. So, surgical procedures. The commonest is what's called a thoracostomy. A thoracostomy is just a small hole in the chest wall. We would do this if we thought somebody had a special type of pneumothorax called a tension pneumothorax. A pneumothorax is where your lung collapses and you have air trapped outside the lung, but yet within the chest cavity. By making a small hole, we let that out. We typically only do this when we are what is called positively pressure ventilating somebody. That's when we are breathing for them. At the moment, all of us sat here, we are all negatively pressure ventilating ourselves. We're creating, using our diaphragm and our intercostal muscles, we're creating negative pressure within our chest cavities, which is sucking the air in through our mouths and our tracheas. And then the natural recoil of our chest is expelling it again. And that's negative pressure breathing. When we take over somebody's breathing and give them an anaesthetic, that of course doesn't work anymore, and we have to blow the air in using positive pressure. that positive pressure can potentially make pneumothoraxes worse, and so this can again be a reason why we do thoracostomies. But of course, you need to be deeply asleep and anaesthetized before we would start making small holes in your chest wall anyway. So don't worry, we'd never do this. In fact, we wouldn't do any of these procedures on anybody who hadn't had a full anesthetic. I'm going to skip resuscitative thoracotomy and come back to that in a moment. Surgical airways, very, very occasionally, it isn't possible to take control of somebody's airway in the conventional method by passing a breathing tube down into their trachea through their mouth. That's the conventional way when many of you will have had your appendix taken out. This is what you will have had done. Occasionally, the commonest reason is massive facial fractures, and no longer are we able to access the airway through the mouth due to traumatic disruption, and so therefore we'll make a tiny incision over the airway in the neck and do effectively a tracheostomy, so we can access the airway and so that we can breathe, pass a breathing tube and breathe for people that way. Occasionally we have to do or complete amputations where people have are in a time critical situation, so they're very poorly and they are trapped perhaps in farm machinery or something similar. Fortunately, these happen incredibly rarely. And then that leaves us with the two major surgical procedures that we occasionally have to do. The first is a resuscitative thoracotomy. This is where somebody may have had a penetrating injury to their chest, and then they have gone into cardiac arrest. So these are individuals who have now lost their output and are effectively dead, and we will perform what's called a clamshell thoracotomy to open the chest and see if we can correct whatever's happened. And there are a number of things that we can correct, and we will do a small operation to the heart, hopefully to relieve pressure on it, and by opening the pericardium. The heart sits within a fibrous sac. In fact, most of our organs sit within similar sort of fibrous capsules, and when there is a small stab wound to the heart will bleed, but it'll bleed into this sac. That sac will then become very taut and under pressure, compressing the heart underneath so that it can no longer beat. If we can open the chest and release that pressure by opening the pericardium, then hopefully, and commonly is perhaps not the right word, but then the patient can survive. And this is well recognised and does happen. And there are lots of people today in the UK who are alive having had this procedure. The other procedure that we might be occasionally called to do is what's called a perimortem caesarean section. Again, this is an operation performed after death. Thankfully, vanishingly rarely do we see ladies in the later stages of pregnancy who have had a significant traumatic event that has unfortunately ended their life. But if we can perform an operation to deliver the baby within those first few minutes after death, then potentially we can save the baby, and actually it gives us a much better chance of resuscitating the mother as well. But fortunately, those are incredibly rare. So, advances in pre-hospital medicine are hugely exciting. In the 16 years that I've been practicing pre-hospital medicine, what we can do and how we do it has changed dramatically. It's a hugely exciting field. Two of the things that I'm going to mention here that in fact already exist and are becoming more and more used. So the first one is called a REBOA. This has the slightly long title of a resuscitative endovascular balloon occlusion of the aorta. So when somebody's had a very significant trauma involving the lower half of the body, so maybe they've experienced a crush injury, crushing legs and pelvis, that can cause catastrophic bleeding. If we can somehow occlude the blood supply to the lower half of the body, then we can potentially control that bleeding, control it long enough to get the patient to hospital and to an appropriate surgeon who can then get some control to the situation. So it's possible to pass a balloon into the femoral artery and up through the descending aorta, and then dilate that balloon so that it obstructs the descending aorta, preventing distal blood flow. Clearly, it's not something that the patient would be able to have for long, but it might just buy enough time and enable the heart, the lungs, and the brain to continue being perfused while the patient gets to hospital. This is already being used on a number of pre-hospital systems in the UK and elsewhere. We don't have it locally yet, and it's, as you can imagine, it's quite technically complicated to deploy. And actually only applies to a very small number of patients that we might look after. One of the other things that is starting to be used across the world is ECMO. And many of you will have heard ECMO being talked about in the last 18 months as it's become quite commonly used for COVID. ECMO is effectively a heart and lung machine. So you put in some large cannulas into the patient's veins and arteries, and the machine takes the blood out of the body, pumping it, and pumps it through a special membrane that provides oxygenation, and then pumps it back into the body. So for patients whose heart and lungs aren't working for whatever reason, the ECMO machine can bridge them. And during COVID, there's lots of people who have become so poorly and whose lungs have become so unwell from the COVID that they have been bridged with ECMO machines in some of the UK specialist centres while they've got better. When people are put on bypass for significant heart operations, valves, and this is the sort of machine that again is used, but on a much shorter time period. So the technology has been used for many, many years, but now we're seeing if it can be used in the pre-hospital environment, which means it needs to become much smaller and much cleverer. And the processes for getting patients onto it need to be much, much quicker. And there are some fascinating studies from across the world, most notably the USA, where patients are being put onto ECMO machines in specialist trials, and the outcomes are really quite dramatic. Unfortunately, all of the research trials do note that you need to have a significant input into your healthcare system to be able to cope with this. If we started appearing at our local hospitals with patients on ECMO, because there aren't the infrastructure within the hospitals to cope with it, it might not work. So this is going to be something that the whole healthcare system will be looking at and developing probably over the next decade or two as the technology and the skills become more readily available. But it's all very exciting. We've got some nice helicopter pictures now. So this is the helipad at St Mary's Hospital on the Isle of Wight. We go to the Isle of Wight quite a lot, and the helipad is just a short trolley push from the hospital. This is the helipad at Salisbury Salisbury District Hospital at Odstock, and we pop in there less frequently. Again, this is a picture I showed you earlier. This is the John Radcliffe Hospital in Oxford. This isn't a helipad, but this is a good example of the places we do end up landing. We had to land in the crop here because the margin around the field was just too close to the trees. For those of you who know the New Forest well, you will probably recognise the car park at Leap Country Park, those very distinctive trees in the background. And it was quite a windy day that day, as you can tell by the water state. This is down by the ferry in Lymington. A much nicer day that day. Beaches are complicated. Our pilots are hugely reluctant to land on beaches. As you can imagine, the sand doesn't do the aircraft much good, and neither does the salt water. But there's always a risk wherever we land that we may have a technical problem and we may not be able to take off again. So landing on a beach, as you can see here where the tide is out, produces a slight bead of sweat on the forehead of our pilots. And the pilots ideally will drop us off and then relocate somewhere else. Or we'll do what we call a hot load, which is where we will load the patient without shutting down the engines, which we don't do often, but in complicated circumstances like beaches or motorways, again, for obvious reasons, everybody would rather that the helicopter didn't break down on a motorway, shutting the M3 for the next 2 days while the part is found and the helicopter repaired. I think this was a park in Havant, and on a winter's evening. We go to quite a lot of industrial accidents, and building sites are quite common, unfortunately, but they can be quite a lot of debris. Downdraft from the aircraft isn't huge. The aircraft is quite small, but the downdraft does need to be thought about and carefully managed, and so we need to be careful to ensure that there isn't any loose debris. Greenhouses and sheds are a prime example as we're coming into land, and again the whole team will be carefully looking out to make sure as we squeeze into somebody's garden that we're not going to be doing any damage or potentially risking the aircraft by flying debris. Some people's gardens are slightly larger, and which again makes it easy. It also makes it much easier for the pilot. Landing in a park, especially after dark, can be quite anxiety-provoking for the pilots because they need to look after the safety of the aircraft and of course themselves. But a nice secure location like this makes their lives much easier. Again here, I'm not sure whether they're below the tide line, but it does look as if the tide is out. But that's quite a dramatic picture. This is a large stately home just outside Romsey, and they were, I understand, very accommodating to the team that day. So, as well as our helicopter Helimed 56, we also have 3 response cars. Helimed HM 57, 58 and 59. We have 2 Skodas and a Volvo, all of which are just perfect for the role. They are all 4-wheel drive and all sort of stocked and able to respond just as the aircraft would. We use the cars when the aircraft is not available, or either through technical reasons or because of weather. Especially at this time of year, as you can imagine, the weather isn't quite what it might be. And if we don't have a cloud base of either 500 feet during the day or 1200 at night, then we're not able to fly. And so the car is hugely useful. As with the aircraft, they have to be carefully maintained, the tyres checked, and before we take the car out on a shift, we have to go through a full checking safety checklist to ensure that there aren't any potential issues that would either mean we don't get where we're meant to be or potentially put any of us at risk as well. Often we're very lucky. There aren't many medical professionals who have this as the view out of their office window. Though often we are thinking and planning about where we're going, or when we're returning with a patient, we're pretty busy looking after them and ensuring they're stable. But occasionally we get to look at the view. And Hampshire is quite nice, really. So, night flying. So we night fly, we fly up until 2 a.m. All of our pilots are specially trained in MVG, night vision goggles, as are our paramedics. So the seats in the aircraft, we've got 2 seats up in the front, 2 seats in the back, and then the stretcher. So up front, in the right-hand seat, the pilot, and next to them is the paramedic. And the paramedics are specially trained to support the pilot in navigation and the various checklists that the pilots need to run through, from landing to taking off, and a whole variety of other bits in between. In the back, I sit just behind the pilot, and then we have a spare seat, which we use for training, either training doctors or paramedics. Very occasionally, pre-COVID, we would have observers, usually doctors or paramedics, who were thinking about coming to join the service, but COVID has pretty much knocked that on the head now. So this is an image at dusk on the helipad at Southampton. And this is us night flying. I think we're just coming up towards Winchester in that image. But as you can see, the views are really quite spectacular. With the night vision goggles, when we're at height, the pilots can see they can see a very long way. They can see the aircraft stacked over Heathrow, because of course the aircraft lights there will be very visible on the night goggles, and it's a very useful asset to what we do. So, how long does it take to make a pre-hospital doctor? Unfortunately, quite a long time. Pre-hospital medicine, well, if we go back to 2012, 2012 was an incredibly important year for pre-hospital medicine, because 2 very significant things happened. Firstly, it was when trauma was networked in the UK. So trauma networks began, trauma centres were designated, and what we now see and almost take for granted as modern trauma care was able to come about. But that wasn't the only thing. The other thing that happened was the GMC recognised pre-hospital medicine as a subspeciality. May not sound very exciting, but this was a humongous step in moving forward pre-hospital care. Until pre-hospital medicine was recognised, nobody could train in it. And nobody could become a consultant in it. The moment that the GMC recognised it, it meant that we could develop proper training programs, and we could start training junior doctors to be pre-hospital doctors. We now have 3 training registrars with us. They rotate in and out of their hospital responsibilities, usually spending a month in hospital and then a month with us. They're usually with us for 2 years. And during that time, they develop and learn all the skills that they need to do. Typically, they've come from either emergency medicine backgrounds or anaesthetic backgrounds, as those will give them the key skills that they're going to need to operate in a pre-hospital environment. But without the GMC having made that step forward, it would have been it was very, very difficult for the speciality and for the care that we provide to develop. So now you can train to become a pre-hospital doctor and do a formal training program. So 6 years at medical school, which typically is quite good fun, though very hard work. Medicine is a little bit like learning a new language. There's so many things to learn. It's not difficult, but it is a huge amount of volume. Junior doctor, typically this is going to take a minimum of 10 years to go through the various specialities and the various levels of seniority to get to the point that you have enough experience and the appropriate qualifications to become a pre-hospital physician. And there's an awful lot of exams along the way, unfortunately, but exams make good doctors. You have to learn it properly, and unfortunately, there's no other way of doing it.